Hello and welcome to our, month are we in? November guest speaker interview. This month's topic is menopause. So I am really looking forward to today's talk. We have a true expert in the field. Nancy Siskowic is going to be talking with us. So thank you very much for coming, Nancy. Before we get started, ladies and gentlemen, I just want to remind you of a few housekeeping items. So first of all, make sure that as you're listening in, that you do mute your computer so we don't get any feedback from our audience at this time. So if you have any difficulty finding that, it should be an icon at the bottom left-hand corner of your screen. Make sure that that microphone has a red cross through it. I also want to let you know that we are definitely inviting questions from the audience today. We ask that you please use the chat function. The button should be at the bottom of your Zoom screen. So press on that and a text box should open up for you. We will have time to answer questions towards the end of our talk. If you are viewing this at a later time, or if we happen to not get to all of the questions that come up, please do let us know and we will try to address these questions in our therapist-led question and answer session next week, which will be put on Facebook, usually on Wednesdays. Lastly, regarding questions, we are asking that we have general questions only. This interview is meant for community education and isn't to be taken as medical advice. So please consult your physician for more information if you have any specific questions about your health. So I'm looking forward to introducing Nancy. I'm going to give you a little bit of information about her. So Nancy Siskowic is both a psychiatric, mental health, and women's health nurse practitioner. She also is a nationally certified menopause practitioner with North American Menopause Society. For the past 27 years, her primary work has been providing hormone consults to midlife, menopausal women, as well as providing psychotherapy. Her background includes mind-body educator with the Deepak, do you pronounce it Chopra? Center for Wellbeing, and possessing a certificate in the Art of Spiritual Direction from Loyola Marymount University, California. She was a guest on Good Morning America, Menopause Special, and on a Lifetime cable channel special, New Attitudes, on perimenopause. She has lectured extensively, both nationally and locally, on menopause issues. Her article, Hot Flash, Hormonal Alchemy During the Menopause Transition, was published in Presence, the International Journal of Spiritual Direction, in December 2008. Nancy is currently in private practice as a menopause practitioner here in our neighborhood in Palos Verdes Estates, California. So thank you so much for joining me, Nancy.
Pleasure to be here, very much so.
Okay, so what we are going to start out with is by defining some terms. So I would like to ask you, what is menopause and what is perimenopause and postmenopause, since we hear those terms thrown around quite a bit?
Good. Let's start with perimenopause, because that begins probably around age 35. Studies tell us that women's hormones begin to diminish from 35 to probably menopause, which is 51 on average, 0.3. Can be 4 years before, 4 years after, but during those 15 years, we have a drop in estrogen. And actually, it's not just a steady drop, there's rises and dips, and those can cause all kinds of problems and symptoms, which I'd like to talk about as we go along. But what happens with women during perimenopause, usually, initially they're saying right around 35, 40, oh my gosh, I have PMS. Just before my period, I'm miserable. Then that PMS stretches out to a week, a couple of years later. A couple of years later, it's 2 weeks. And a couple of years later, it's the whole cycle. And then eventually their periods stop. Once your periods stop, you're really considered menopausal. However, the definition of menopause is 1 year past your last period. So postmenopause happens, at when you stop having periods. One interesting fact, women can drop an egg in those first couple of years after their last period. So there's always a question about fertility and contraception. And I just want to add one more thought here before the next question, and that is 50. That's young. We live 30 to 50 years beyond menopause, beyond having hormones in our bodies. So I think we want to think about our health, which we'll be talking about today.
Yes. Oh, wow. So I can relate with some of the things you're talking about. And before we started our talk, you did send me a copy of an article that you wrote, and it resonated with me because even at 39, I am starting to see some of these symptoms in myself, and so yes, it really resonated with me. So, are the signs of perimenopause? It sounds like from what you said, it's the case. They're very gradual for most women, and it's not necessarily that there's a definitive sign that you are entering that stage of your life.
No, for most women, they begin rather insidiously. They don't even realize that they're feeling anxious and irritable and all these kinds of things.
Mm-hmm.
And shall I just talk now about the symptoms that then start to occur across the cycle?
Absolutely, yes.
Okay, so we do know this. The 5 years before the last period and the 2 years after the last period are for most women the most tumultuous in terms of symptoms. They're having hot flashes and night sweats. They can't sleep at night because a hot flash brings on a surge of adrenaline. And what does adrenaline do? Well, at night, it keeps us wide awake. During the day, even at night, we can feel anxiety, anxiousness, our heart can pound. So these hot flashes and night sweats can really play havoc with us emotionally and physically. We also can have depression out of the blue. We can be sitting and, just like maybe an anxiety attack would come on out of the blue, so can sadness, tearfulness, depression, because a good number of women, almost half, also have drops in something called noradrenaline. And that causes this feeling of sadness. And it's totally confusing. What just happened to me? Why am I crying? And then you're fine. But by George, there's another one of those just around the corner. So crazy making. Women complain of brain fog. They walk into a room and wonder, why did I come? Or they forget the name of the movie they just saw, or the name of somebody that, they know well. Start a sentence. What was I going to say? And these are frightening kind of symptoms. Women are thinking, am I getting Alzheimer's? Am I getting dementia? They're not. They're simply perimenopausal. It's kind of as if the volume is turned up on every single emotion a woman is feeling. So where you used to be able to handle things okay, not now. It can be way out of proportion. Also, and this is one of the things I hear most, women are complaining of I'm gaining weight, especially around my middle. And that's very true, simply because as estrogen levels diminish, the body wants estrogen. So what does it do? It puts on fat cells. This is a wisdom kind of thing, I think. Puts on fat cells around the middle because it needs fat cells to make a little bit of estrogen from the testosterone that our ovaries are still kicking in. And so this weight comes on because the brain is saying to the ovaries, give me estrogen. They're not responding. And so, okay, I'll put on fat cells. I'll make a little bit of estrogen. And you can't lose it unless you take estrogen. And the brain gets it that it's back, then you will be able to let go of some of that. Now, testosterone I just mentioned. Because there's still testosterone, but very little estrogen, that testosterone can cause havoc, hair loss. Especially in a woman whose family has male pattern hair loss, she may notice that there's considerable hair loss, and that can be frightening. And then just one more quick thing that we can go back to, but libido. Oh my goodness, that is one of the biggest complaints. Libido is gone. Where did it go? I have no desire. Can't achieve orgasm. And so that to me is pretty tragic because statistically, at 62, women are not having sex if they don't have estrogen. I find that really, really, really tragic. I'm a good deal older, and I can tell you I enjoy sex with my husband very much at my age and I hope to continue that. So with the loss of libido also comes vaginal dryness and itching, and just intimacy behaviors go out the window because women don't want to cuddle with their partners. They don't want to, get up close on the couch or give hugs because then their partner's going to want sex. Oh no, I don't want that. So all of these shifts and changes are going on insidiously at first and then full blown.
Okay. Yeah. Oh, wow. Yeah. I think we hear about those things with so many women. And,
Yes.
and I don't think a lot of women do realize that it is that related to how your hormones are changing during that time. So now when somebody reaches menopause, which as you defined, 12 months without a period, so it really is just a brief second in time. It's not that a long drawn out thing. There's perimenopause, which sounds like it goes on for quite a long time, and then you're postmenopausal. Is being postmenopausal any different to being perimenopausal, or is it the same?
Yes and no, but yes, because you can continue to have all the symptoms that I just talked about. In fact, for some of them, like the vaginal dryness and such, that can get worse with time. But also what's going on when estrogen reaches its bottom, if you will, is we begin, or even before that, even during perimenopause, we begin to lose bone mass. We've seen probably a 20% decrease in women's bone mass from age 35 to 50 in many of them. We also, without estrogen, begin to build up plaque in our coronary arteries. So arterial sclerosis is something that we need to look at. Of course, like I said, sex is gone, but then also as briefly mentioned that, women think they're getting dementia or Alzheimer's. They're not, it's perimenopause. However, with many years without estrogen in our bodies, we are statistically more set up to develop dementia and Alzheimer's. I was at a talk a couple of years ago, and the physician said, billions of dollars has been spent on trying to find a cure for Alzheimer's. They haven't. The one thing that consistently helps keep it at bay is estrogen. So I think that is a phenomenal piece of information for women to realize.
Yes, absolutely. I mean, and several of these things that you've mentioned, the dementia and the cardiovascular problems, the osteoporosis, I think we see so many women with those types of comorbidities come into the clinic, and I think that how much these things impact their lives, and our goals are often to make sure that they can do things like exercise, for example, to make sure that they can help combat some of these problems that can just get worse with age. And we see so many women with things like incontinence, which can be a barrier for wanting to do any kind of physical activity. So that's in our clinic, in our practice, we're definitely trying to make those kinds of things happen. Those better life and health habits, even diet and nutrition and things like that. We'll talk a little bit later about some of our favorite pillars of health that we want to make sure we're advocating with our patients.
Good.
So we've been talking definitely about estrogen, but you've already mentioned some of the other hormones that are at play. And so I think it's important for people to understand that it's not just about the decline in estrogen, but it's about the balance of estrogen with a lot of these other hormones.
Correct.
Yeah.
So talk about that more?
Yeah. Yes. If you have anything to elaborate on that, please do.
Certainly. Well, estradiol is the most important hormone that we want to replenish in our body when we don't have it anymore, or even when it's beginning to diminish. If we have a uterus, then we need progesterone. Progesterone is protective. It helps prevent uterine cancer down the road. Years ago, women were given only estrogen, and 5 to 7 years later, many did develop uterine cancer. That happens no more. There's no more of a likelihood of uterine cancer taking estrogen than taking nothing, if you're taking your progesterone. And then, of course, testosterone. When we're 20, it's at its peak. When we're 48, it's down by about 50%. And that, to me, is a very key hormone to replace a bit of. It's not FDA approved yet. Hopefully one day it will be. But I prescribe often a testosterone cream that women can use, and that helps them sexually, and it helps the vaginal area also, the vaginal tissues. I do want to say this, that women who have surgery, have their uterus removed, if their ovaries are removed, they're bingo in menopause, whether they're 35, 37, 45. But those who just have their uterus removed and ovaries are left think, well, I won't go to menopause until, I'm 50. Not so. Studies tell us that in 6 months after a hysterectomy, 25% of women lose function of their ovaries. Within 3 years, 40% of women lose function, and within 7.5 years, 100%. So a 35-year-old woman who has her uterus removed, ovaries left, is menopausal at 42. And we need to understand some of those things, because without estrogen, these women, studies, and there have been some excellent studies, show us that tens of thousands of women who've lost their ovaries or who've gone through menopause without replacement die before the age of 70. So we don't want that. We want to keep women as healthy, their bones, their brain, their hearts, everything as healthy as we can.
Yeah. Wow. Now, I know that we've talked about, and you started to mention how important estrogen is. So what, if you prescribe estrogen, tell us about the different types of estrogen that you might be prescribing in terms of whether it's a systemic or local. How is this estrogen applied? Can you elaborate a little bit on that?
Certainly. So most women coming to me are really suffering, and they need systemic, and I offer systemic. You can get systemic estrogen in patches, pills, creams, gels. I happen to love, and I want to say this, I've been doing this for like 28 years. And throughout those 28 years, I think I've tried every product on the market. I always have gone back to the patch. I love the patch. You put a little patch on your lower abdomen, it gets your estrogen up, it keeps that estrogen up around the clock, 24/7 for 3.5 days. Take that patch off, put the next one on, and you're just held steady state estrogen, which is the best. Creams and gels are good, but you need to put them on often twice a day, and you get sort of rises and dips. So, but they can work fine. The other problem is with creams and gels is you have to watch for the first hour or so, because you can transfer some of that hormone to male, children, babies. So you have to watch where you put it and who you're touching. Pills used to be the big thing. I don't prescribe pills anymore, because we did find that oral estrogen, when it goes through the liver, can raise the possibility of blood clots and strokes. So minimally, but I don't want to take that chance. So like I said, I love the patch. There are now the pellets that people are using. However, those are not FDA approved to the best of my knowledge, and they're pretty expensive, and so I haven't looked into those. I'm not interested in doing that. I love the patch. I love my patch. I want my patch on my belly the day I die. I love it that much. Okay. So, along that line, the greatest benefits to us women and all these things we talked about, the heart disease, the osteoporosis, the brain, really are helped in the first 10 years immensely. Using estrogen for at least 18 years increases our health.
Wow.
When we stop estrogen, we can go backwards. So the question is coming up a little bit later, but let me say it right now. women hear, oh, you have to stop at age 65. Actually, I get letters from Medicare all the time. This woman is too old. You should take her off estrogen. I can tell you there is absolutely no study, no data, none, zero, zip, that says we have to take a woman off hormones at age 65. We can stay on them a long time, till the day we die. The other thing is, now it just escaped me what I was going to say. It'll come back. So
Okay.
let's go to your next question. Oh,
Well,
I just remembered, I'm sorry.
That's okay, go for it.
In the inserts for hormones, it says, use the least amount for the shortest period of time. And so, because if you don't, you're going to develop heart disease, all kinds of stuff. And there's no data that says any of that. We want a low amount. We don't want too much, but we want effective dose. So I always say to my ladies, the least effective. If it's not effective, you need more. We can't make a decision based on like a blood test. We go by symptoms. Symptoms are key, and women need to listen to their bodies. And if they're still having symptoms, go back to their practitioners and say, I need more.
Okay. Yes. So when you are prescribing this kind of therapy, are you doing blood? Is it usually just based on symptoms, or are you ever doing blood tests to monitor whether or not their levels are within considered normal limits? What are you doing to help guide that?
Okay. Well, so I said hormones start down at age 35 and hit bottom on average age 51.3. Okay. If I were to measure a woman who has stopped having periods, it would be less than 10, her estrogen. I know that. I'm not going to waste her money. If I were to test her between 35 and 51 or whatever, her estrogen is up high 1 minute and down low the next, up, down, all over the place. So we can do a blood test, but we're getting a single moment in time. We're not getting any true picture. So many women happen to catch the up moment, and doctors will say, well, you're fine. You've got plenty of estrogen. 10 minutes later, it could have been at the bottom. The one hormone, so I go on symptoms. I have a symptom checklist that women fill out before they come in to see me. It's kind of my Bible, if you will. The one hormone occasion, but I will. If a woman says, Nancy, I want to know, I'll measure. Here's another thing I do know, that, for instance, the patch comes in different doses. I know how much is delivered to the body, so how much the blood test would tell us she has, if she has her patch on. I don't need to pay $100 to find out that information. The only one I was going to start to say is that I do test sometimes, and occasionally, is testosterone. But mostly I prescribe it if a woman wants it, and then tell her what to watch for symptom-wise if she's getting too much. So, we can monitor ourselves quite nicely if we know what to monitor for.
Yeah. Now, in 2002, the Women's Health Initiative, the hormone replacement therapy started to get a little bit of a bad rap at that point. Can you tell me a little bit about what was said at that time and now what the general consensus is, as it seems to have shifted?
It is shifting, thank God. Back in 2002, when this study canceled, the person who spoke said, get your women off hormones. 24% increased risk of breast cancer, 100% increased risk of blood clots. 40-some% increased risk of heart attacks. I mean, it was frightening. Women heard that and went off hormones. Doctors stopped prescribing. Doctors were sued back then because if a woman got breast cancer, they were sued because, well, the study says. Okay, so now, if everybody listening would put these couple of figures in your heads, there were 5,000 women in that study in a placebo group. I'm sorry, 8,000 women in a placebo group. In that group, in 1 year, there were 30 breast cancers. So these are women not getting any hormones, 30 breast cancers in a year. In the treatment group, which was Premarin and Provera, there were another 8,000 women, so 8,000 in both groups. In a year, there were 38 breast cancers. It wasn't 1 out of 4 women. 8 is 26% of the 30 in the placebo group. It's really actually in the rare category. It should not have stopped anybody from taking hormones.
Mm-hmm.
Blood clots. In the placebo group, the sugar pill, there were 11 blood clots in a year in those 8,000 women. 100% more in the treatment group, Prempro, 22. It wasn't every woman. It was 100% more than in the other. Now, we've known forever that oral estrogen, and Premarin was oral, birth control pills are oral. We've known forever that oral estrogen can increase the risk of blood clots and strokes. That was not even new information. So anyway, it was just so horrifically reported. And I'm just going to make one more comment. The women in the group aged in were in the age of 50 to 79. The average age was 62. So the average woman was already 12 years past menopause without hormones protecting her. The group was a more obese group than normal women. There were more smokers in that group than on average in the population. And so we had a less healthy group. The statistics were mostly in the older group beyond the 62, not in the young group, the heart attacks, strokes, and blood clots. But they lumped everybody together, which they should never have done. They should have broken it up into the 50 to 59-year-olds, 60 to 69, 70 to 79. Now, since that time, some of the best experts in the field have gone back, looked at those statistics, and what they tell us today clearly is estrogen does not cause breast cancer. Provera was a bit of a culprit in that study, but it was minimal. There might be a minimal increase in some women, but the advantage to the heart, the bones, the brain, when you put it all together. One more thought.
Yeah.
Woman taking hormones at the time of diagnosis fares better, has less mortality, lives longer. So even if a woman is diagnosed with breast cancer, she's going to fare better if she's on hormones.
Yeah. Yeah.
Any questions about that?
Well, I think that's I think that is excellent information for a lot of us to hear, because I can count on way more fingers than I have how many patients come in and they talk about how their doctors don't even want them to be on a local estrogen because there has been a risk of breast cancer in their family, and you see the types of comorbidities based on these changes in estrogen that they're going through, and sometimes you do wonder what is going to what's the lesser of two evils, and not that one is even evil at that. I think that that it's important to get this information out, that that's not always the case, and that study is obviously has been misinterpreted on many levels. So yeah, that is fascinating. What
may I make one more comment, however?
Yes, please.
Because you're saying doctors say no, you shouldn't because you have a family history.
Yeah.
The North American Menopause Society, which is made up of incredible experts in the field, has done a lot of looking at that. And what in their consensus statement that came out 2 years ago, estrogen does not cause breast cancer. If you have a family history of breast cancer, you do have an increased risk. Taking estrogen does not increase that risk further. And that's clearly stated in this consensus paper. And that's clearly the thinking of today.
Yeah.
That which is just vaginal pretty much remains in the vagina. Such a minuscule amount gets into the bloodstream. Probably not even as much as, our own bodies making a little estrogen from our own testosterone in our fat cells in women who, well, anyway, so I am not concerned about estrogen and breast cancer really at all.
Okay.
We can talk about that at the end if you'd like.
Yeah, definitely. We'll touch on that a little bit more. So there's a long list, as we've already talked about, of problems that are associated with perimenopause and menopause, like the mood changes, sleep disturbances, hot flashes, weight gain, vulvovaginal symptoms, osteoporosis, heart disease. The list just keeps going on. In addition to the hormone therapies that you do recommend, what other types of lifestyle changes do you tend to recommend? Do you have any pillars of health that you advocate for in regards to sleep and diet, hydration, exercise?
Sure. And I must say, with each patient I see, I spend an hour. With a new patient, I have 2 visits. Each one is an hour. So I listen to all their concerns. I educate them about menopause, as we've just been doing here. I talk about hormones, and then I educate about what the hormones might, what side effects might or might not occur. And then, how is your health? How is your sleep? How is your diet? What supplements are you taking? And I go into often quite a bit of detail. I want them eating well. I want them exercising, not cardiovascular as well as weights. A lot of women are quite stressed when they come, so sometimes I'll just do some breath work with them. I often recommend Dr. Andrew Weil. Do you know who he is?
Not familiar with that name.
Andrew Weil he's a guru, I think, for relaxation, but he has a YouTube video on 4-7-8 breath work. Taking a deep breath into the count of 4, holding for 7, and blowing out to 8. And if anybody right now listening is feeling stressed, I would say listen to Dr. Weil, and he will teach you a wonderful, wonderful breath technique that not only helps during the day, but I use it often at night if I wake up and I can't get back to sleep. So I'm working with all these things with women. And I think I mentioned supplements.
Mm-hmm.
I ask every one of my women what supplements I want them, surely on vitamin D. Turmeric, I think, is important, calcium, magnesium, vitamin C. So I try to be sort of a total body person when I'm dealing with my women. And I'd like to ask what you would add to that.
Yeah, well, I think we overlap quite a bit. I think some of my patients probably wonder why I'm coming in for incontinence. Why are we talking about my sleep or my stress? And so I try to explain how important that just the foundations of health really matter. And so
Yes.
absolutely, we talk a lot about hydration is a big one to help with the bladder and the bowels, and like we talked about stress reduction. I definitely talk about breathing, and so I'll have to look into Dr. Weil's videos, and so I can refer those off to my patients, and because I'm always looking for good resources, free resources, easy resources that people can easily add to their life, because I think that people can get overwhelmed with the number of different things they're supposed to be paying attention to for their own health when they have all these other life problems, work problems, social problems that are going on in their lives and in the world. So I think it's nice to be able to give them very basic information.
Absolutely.
And easy to apply information.
Yes.
Yeah. So to shift gears a little bit, kind of back to hormones. Are there any common changes in the thyroid when it comes to menopause, and what kind of things do you look at in terms of that?
Yes, there often are changes in thyroid when women go through menopause. And so one of the things that I always ask is, have you had blood work recently? And if not, please get it done. And I want them to know what their cholesterol level is and what their thyroid levels are, because women can develop hyper or hypothyroid. Hypothyroid, my goodness, you're fatigued, you can feel depressed, you can have hair loss, weight gain, all the same kind of symptoms that you can have with perimenopause.
Yeah.
When I'm seeing a woman, I'm also looking at a whole lot more symptoms than just those. Periods, how how heavy, how light, how long, how much in between, libido and lots of other things that are really more tied to hormones. But definitely women in midlife need to have their thyroid tested to see what's going on. Very, very, very key.
Yeah, yeah.
Yeah.
Let's see, with in our clinic, we're often addressing changes with menopause, including urinary problems, fecal incontinence, pelvic organ prolapse, and pelvic pain, like dryness and pain with intercourse. Can you touch on a little bit about what effects does menopause have on the genitourinary tissues that tend to cause these types of problems?
The genitourinary tissues are loaded with both estrogen and testosterone receptors.
Mm-hmm.
They ain't getting none. Is how I like to say it to my ladies. When your estrogen has bottomed out and your testosterone is down by 50%, that's when you begin to, and it's usually though, maybe about 4 years after that bottoming out of estrogen, that women really begin to have severe dryness, tightening of the opening. The vaginal tissues just get very thin. They can bleed easy if they have intercourse. Even walking for some women can be painful. Those women who remain sexually active because of the stimulation to the tissue may slow down that decline, if you will, a little bit. But eventually it probably will catch up. And the sadness in postmenopause and these symptoms is that with time they don't get better, they get worse. It's kind of it's a condition that just you have unless you step in and treat it. And of course, it's far easier to correct a problem if you step in and treat it early in the game, rather than wait too long and have vaginal atrophy have set in and a lot of other kinds of changes. So I'm always encouraging women to get to the doctor, get those hormones.
Yes, yes. Do you ever advocate on any particular lubricants that you like to recommend to help with intercourse?
There's lubricants and there's also moisturizers.
Yes.
And so I will recommend that women use moisturizers. And so that those you would use maybe 3 times a week, more or less, more perhaps. Replens is a good moisturizer. And then lubricants you want on hand for sex. And lubricants are used, as you would call it, as needed. And there's several good ones on the market that are oil-based or silicone-based. Astroglide is one that comes to mind. KY jelly, KY, no, I'm not sure. But anyway, there are some that are oil-based, and those are not as good if a woman is worried about condoms. And because the oil-based, like petroleum jelly, that could cause a condom to sort of disintegrate or not be effective. And so the water-based, and there's plenty you can look at the shelf. Gynemoistrin is another one. There's many of those on the market to be used.
Yeah. Well, we're running out of time, so I'm just going to touch briefly on one of my other favorite topics that if you're one of my patients, you probably know that I ask about bowel health quite frequently. and so I'm a big advocate of preventing things like constipation. I've heard that with menopause, conditions like IBS, irritable bowel syndrome, can pop up more, as well as understanding that things like constipation can really have an impact on the urinary system and pelvic organ prolapse. Is bowel regularity or gut health anything that you will touch on when you're talking with patients?
Probably not as much as you do, but I will touch on it. And I think probiotics are one good addition. I also think magnesium citrate for women that are constipated. I have a little bit of a colitis-y thing, so I take magnesium glycinate, and it does not loosen my stools. But magnesium citrate, I think, taken at bedtime can be good for women. But beyond that, I don't talk about diet, certainly. lots of fruits, lots of veggies, what is going into their body, less constipating foods like cheese and such. But I don't spend a tremendous amount of time on that.
Yeah.
Actually, I don't ask the question. It's not on my checklist. Therefore, we don't talk about it as much. Interesting.
Okay. Yes. 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 Well, before we wrap up, Nancy, I want to make sure that anybody listening via our Zoom meeting knows that they can ask those questions in the chat box below. So I want to make sure we're going to have a little more discussion, but if any questions come up, please use the chat button below. And so while we're waiting for any questions that might come through, Nancy, I want to talk with you about your book. That you wrote a book recently, and it's pre-released, about to be officially released next week. So can you tell us a little bit about your book and why you wrote it?
Sure. I was diagnosed with breast cancer in 2017, and that was a shock to me, although it wasn't. My grandmother had it, my aunt had it. Grandma died at 93, my aunt died at 100. So I wasn't really terribly concerned when I was diagnosed. I also, because I know when you're taking hormones, you fare better, I kind of suspected I would, and I did. It had not spread. It was not terribly aggressive. And but everybody said, you've got to go off hormones. It'll kill you. I did. I went off for 4 months, and it about killed me. And so I did a tremendous amount of research and study, and actually went to a physician at City of Hope, went back on my hormones. And if we have time, I would just even love the whole book. The whole memoir is about my life when I was younger, that has helped, sort of form me into the woman I am today, how life has just carried me along, brought me where I am. And then I journaled during the breast cancer and all the ins and outs of that. So a lot of my feelings, my emotions, my questioning, and I think we do need to question and challenge, is all in there. And anyway, I think it could be a good read, because I also tried my best to educate by talking about my own symptoms and what I've learned, and try to make it a very personal experience of. And I can tell you this, having had that experience, I'm more of an advocate today than ever for hormones for women. I so believe in it. But if we have time, I'd love just to read a couple of paragraphs.
Please do. Yes,
from
that
the
sounds wonderful.
And the name of it is The Menopause Lady.
Mm-hmm.
And it's a menopause practitioner's memoir of life, love, breast cancer, and her choice to return to estrogen. So this is that one little excerpt. My husband and I visited an oncology gynecologist at City of Hope. She had read all my notes, asked questions, and actually listened. I shared my story of not being able to remember words, such as the time I forgot the word orchid. One day I struggled on and off all day simply to write a thank you note for a beautiful orchid plant I'd been given, but the word escaped me completely. Finally, in desperation, I Googled houseplant that blooms, and there was my word, orchid. I finished my note, but then I sat there in defeat and desperation. My brain felt wasted, completely shrouded in fog. How could I continue to see patients? How could I continue to offer my menopause seminars if simple words were gone? Not just slow to surface, completely gone. It was a painfully jarring moment for me. But the caring doctor at City of Hope listened to me talk of my self-isolating behaviors, which had come back with a vengeance, my now absent zest for life, the sadness and tears that overtook me, how I could even see my skin becoming drier without estrogen. Plus, a recent bone density showed that I had already had osteopenia, meaning that I had lost bone mass, and I knew going off hormones could drastically cause me to lose more bone. That raised my fear of hip fracture, which could kill me. I felt as if I was aging rapidly before my very eyes. The response I received, we also talked about my horrific family history of heart disease, stroke and Alzheimer's. My father and 3 brothers died of strokes. A 4th brother has Alzheimer's. A sister had Alzheimer's. So my family history is horrific. Her response toward the end of that warm and personal visit contained the most beautiful words I had yet heard from anyone. I support your going back on estrogen because of your family history, your symptoms, and because I believe there are women whose brains simply do not function well without estrogen. Hope was creeping back. It was a beautiful moment.
That really is. Yeah. Oh, it's so wonderful that you can find somebody that really truly listened to you and didn't just think about the 2002 study and say,
Yes.
no, that's not an option. I think that's great to really listen to what you really wanted and and understanding what you were asking for and the other type of worries that you were having. So where can we find your book? When is it exactly released and where can we find it?
Well, it's on Amazon.
Okay.
Menopause Lady.
Mm-hmm.
I'm going to send you the link tomorrow,
Mm-hmm.
and a little email that on my website also. My website is nancysiskowic.com. We might need to spell the Sis. Well, let me spell it. SISKOWIC.com. And on my website now, I have the link to the book. And also, there's other interesting information on there for anybody that might want to go on to it.
Yes, definitely. And that was one of my questions for you was how do people find you? So I assume that if they wanted to find you, they could go to your website.
Absolutely.
If anybody happens to be listening from afar, are there any resources for finding others like you that have a specialization in menopause?
Again, I belong to the North American Menopause Society.
Oh, great. Yeah.
Go to that, click on looking for a menopause practitioner, and then you put in your zip code and they will put names in there. There are names of women, or men and women around the country who are specialists in menopause.
Mm-hmm.
That's
the
best way to find, yes.
Okay, perfect. Well, I think I'm checking and I don't see any questions in our chat box, but like I mentioned earlier in the talk, if anybody has questions, please, you can look on our Facebook group, and this is live on our Facebook. You should be able to ask any questions through Facebook, or feel free to send an email to our clinic and ask a question, because next week myself and one of our other therapists will be doing a Q&A session on Facebook regarding commonly asked questions and any questions that we get in response to our monthly interviews and webinars. So if any questions come up, we're happy to be talking or to answer. If anything, if you have a specific question for Nancy, I will make sure to get in touch with her so I can include her response next week. So stay tuned for that. I also want you to stay tuned for next month. Next month, our topic is going to be bowel health. So we're going to be discussing some of the common things that we find in our patients with bowel problems like constipation, fecal incontinence, problems after surgeries and things like that. So we will be doing a research talk. We will be interviewing one of our local naturopaths on what he sees with several bowel conditions and some of the nutritional and supplemental considerations regarding them. And then and that will be what we do for next month. So please, ladies and gentlemen, stay tuned for that. Nancy, once again, thank you so much. This has been wonderful, loads of information. I can't wait to share this video with all of my women, friends, and family and patients, because I think it was quite fascinating, and you really were easy to understand and very clear, and answered so many of my own questions. So thank you very much, and good luck with the release of your book. I'm definitely going to be picking that up. and also sharing that, because I think that's wonderful.
Good.
So yes, thank you very much, everybody. We will look forward to seeing you soon. Okay, thank you. Bye-bye.
Bye now.